So I think without further ado, I've introduced myself. I'll start with the first talk, and I've been asked to talk about the true course of Lyme disease in the UK, which is an interesting topic because it's become a fashionable disease and a cause for a lot of controversy. So I want to try and cover that in the session today. Now, this is what we normally think about in terms of the areas where you might acquire Lyme disease, the sort of rural idyll of southern England surrounded by, populated by deer, where you might pick up a tick that might transmit a Borrelia infection. It's not just the New Forest, of course. The epidemiology of Borrelia occurs throughout Western Europe and Eastern Europe in varying degrees. But the disease itself of Lyme disease has been sort of divided recently by this rather unpleasant proboscis of a tick into two camps. Which I think is a great shame. There's a parallel universe of Lyme disease that has developed across the world. It's not just in Europe. In fact, it started in the US, and this parallel universe of Lyme disease has passed across the world to virtually every continent. And I'll explain what is going on there, because I think most of us in this room will be in the camp where, the sort of scientific camp, rigorously scientific camp, which regards Lyme disease and the left-hand column, that a disease that occurs focally, that's transmitted by infected ticks, that presents with objective clinical findings and requires a laboratory test to confirm the diagnosis. And when that diagnosis has been confirmed, patients tend to respond pretty rapidly to short courses of appropriate antibiotics. But there is another view, the parallel universe view of Lyme disease, which is that this disease is insidious and ubiquitous. It occurs everywhere. It may not even be transmitted by ticks. There's some views that it could be transmitted by other arthropods, and indeed possibly even person to person or vertically from mother to baby. It presents with non-specific symptoms alone and can only be diagnosed on clinical judgment. Laboratory tests are often not positive, not confirmatory. That the disease may require months or years of antibiotics to cure and can only be diagnosed and managed by Lyme literate doctors. So this is the parallel universe of Lyme disease, which is a difficult problem to control. There are lots of patient advocacy groups across the world, some of which are frankly quite aggressive in their approach to their supporters' illness. This is, in my view, the most responsible patient advocacy group. And I don't know whether there is anybody in the audience from Lyme Disease Action, but it would be helpful. Is anybody here from Lyme Disease Action? Because I think they're a very useful patient support group. And if you have patients who have chronic Lyme, seronegative Lyme, I would recommend that you put them in touch with Lyme Disease Action, because they are responsibly trying to support those patients who have these chronic symptoms and find some solution for them. But Lyme Disease Action believe that there's just this huge gulf between clinicians and patients in terms of the chronic disease, and that gulf may never be bridged, who knows, but we need to try and work on it. So there are these two syndromes, Lyme disease transmitted by Borrelia burgdorferi and chronic well, I'm trying to develop a new acronym, a new name for the chronic illness, because it is a totally different disease from true Lyme disease. And I think we should call it chronic arthropod-borne neuropathy, and I'll come on to develop that theme as we go through the talk. We all know what causes Lyme disease. It's Borrelia burgdorferi, the different strains, and the antigenic, there's antigenic variations, geographical antigenic variations, based on where you acquire your Borrelia. So in the States, there's Borrelia burgdorferi sensu latu, and in Europe, there's different strains of Borrelia that have different antigenic structure, and probably, and that's probably responsible for the different clinical presentations, whether it's just dermatological or whether there's neuroborreliosis. more work needs to be done on that. And as a slight aside, many of the chronic Lyme believers, as I've mentioned, believe that Lyme disease is ubiquitous across the planet, but certainly across North America. But actually, if you look at the confirmed cases from CDC in North America, and each one of those dots is a serologically confirmed case, they are mostly along the eastern seaboard of the United States, which is, of course, where the first European colonizers arrived. So I think that fits in with it being a European disease that was brought over to North America by Europeans. If the disease was much older in the North American continent, you would have expected it to have come with the early colonizers across the Bering Straits and for it to be much more widespread throughout the continent. This view of a European disease, I think, is supported by molecular phylogeny, which you can see in the bottom right, which shows that US strains are genomically separate as a population from the European strains and diverged at a point sometime in the past, but I suspect brought over by a chap like this. So that's just an interesting observation. Borrelia are complex organisms. They're complex spirochetes with a variety of surface proteins, which is why the serology is also so complicated. When we send back reports from Ripple, from the Rare and Imported Pathogens Laboratory, I think the reports are actually quite confusing for those of you who receive them and have to try and interpret them. They currently report all the bands in the immunoblot, which has come about because of these patient advocacy groups who insist on having every bit of detail in terms of their serology. They want to know which bands they have responded to. But I think it's not terribly helpful for those of you trying to treat patients and trying to interpret the results. So I want over the next few months to try and simplify that reporting process. But the difficulty is that these spirochetes do change their antigenic structure fairly frequently. So when they're in the tick, they express certain proteins which are designed to allow the spirochete to attach to tick tissues. But as the organism passes from the tick into the mammalian host, then those expressed proteins do change. This one down the bottom, which is the main attaching protein, goes from OPS-A to OPS-C, and that's one of the earliest expressed proteins in the mammalian host, which elicits an early antibody response. So antibodies develop against certain spirochete proteins early on in the disease, and these evolve and change as the disease progresses. So you will not only get a change in the IgM response, but also a change over time in the different bands in the IgG immunoblot. The organism, of course, multiplies locally at the site of the bite, and then can disseminate through blood and lymphatic tissue, and classically in the UK, unlike in the States, causes neuroborreliosis. In North America, it's much more common to have arthritis. Arthralgia is not uncommon in the UK, but frank arthritis is, to be honest, pretty rare with European strains. And then myocarditis is pretty rare. And chronic skin conditions like acrodermatitis chronicum are really pretty unusual because most patients in Europe are treated reasonably early on, so they never develop these chronic changes. There's a common antibody to the VLSE protein, which appears early and often remains as an IgG, as one of the bands in the immunoblot for many years afterwards. But the VLSE protein has a conserved region here in orange, but the rest of the protein is very variable. And this sort of allows the organism, in a sense, to evade the immune system. But, of course, this conserved region is always present, and that represents the main protein for quite a few of the ELISA tests, certainly the C6 ELISA test that Ripple use as the main screening antibody. But the protein itself may evolve and develop as time goes on. So the Rare and Imported Pathogens Lab, which is the national reference laboratory for Lyme disease, they took this over from Southampton in June 2012. And they currently use a two-tiered testing system. They use a basic C6 ELISA, which actually is a very sensitive test. If anything, it is too sensitive. we don't really use the immunoblots, we don't really use the technique of immunoblots much for diagnosing other infections. So you might ask, well, why are we using it for Lyme disease? Well, the real purpose of the immunoblot in Lyme diagnosis is to rule out the false positive C6s. Because it is such a test, it has very high sensitivity, but there are a number of false positives which the IgM immunoblot helps to resolve. Ripple are now using a printed blot system, ViraStripe, which is machine readable, and so it's read by a densitometer and has less background interference. So I think it helps with the interpretation of that. This is just the Lyme C6 assay, and these are the printed, well, in this case on the screen, but comparing the control blot here with a test sample with all the antigens laid out on the blot and readily readable by an automated densitometer. And we use a printed blot now because, for the reasons I was saying, that it's much easier to read than a standard blot, which has lots of background interference and variable band density. So you only have the bands, the antibody bands that you want. And so this is the sort of result that's being sent out at the moment from Ripple, which I appreciate is pretty confusing. But as I explained, the reason they're doing this is because of the patient advocacy group demand that every aspect of the test is reported. But I think we need in Ripple to simplify that reporting system so that it makes it easier for not only microbiologists and infection doctors, but also for patients and GPs to understand as well. But this lists most of the proteins that are on those bands. I now want to move on to our Lyme cases, true Lyme cases, serologically confirmed, that we have seen in southern Hampshire over the last 20 years. Because since I've been a consultant in Winchester, we have tried to actively seek out every patient who has Lyme disease from our local GPs, from those that are referred up to hospital, so that we've got a good picture of what's going on locally. Because as I mentioned, it's not just the New Forest, it's certainly many areas over the south of England, and the incidence is I think genuinely seems to be rising. So this is about 20 years of confirmed Lyme cases, and you can see it would appear that the numbers are going up. Now, is that a true rise, or is that just related to better diagnosis? I think there is a true rise, because we were just as interested in the early 90s in Lyme disease as we are now, and we were actively seeking cases from our GP practices in Hampshire, but there weren't that many cases, and I don't think they were really being missed. So I think there has been a genuine increase in the south of England in Lyme disease, possibly related to increased housing development in rural areas associated with woods, and possibly more exposure to the countryside. I think another reason might be that there are more vectors out there. I mean, not just ticks, but the intermediary hosts as well, which are not just deer, they're small mammals and indeed pheasants. At this time of year, with the shooting season starting in Hampshire, you can hardly drive along a road without running over a pheasant, because the numbers of birds that have been put down specifically for game shooting are huge. They all carry ticks. They're known to carry Borrelia as well. So there are many different hosts out there in the countryside. So I think this is a true rise in incidence. And this is the same numbers, but this is translated into incidence per 100,000 of the population. Now, if you look up the PHE website, the national rate of borreliosis in the country is 1.7 per 100,000. But you can see in some years in our area of Hampshire, we have 10 times that, 18 per 100,000 in the population. So I think that is a genuine increase in incidence. But that's nothing compared to other parts of Europe. And this is some data from other countries in Europe. 206 per 100,000 compared to our 18 in Slovenia, based on laboratory reports, and 135 per 100,000 in Austria. Again, based on physician surveys. So very high. You're all aware that it's transmitted by exoded ticks. And we've asked all our patients over the years, have they been bitten by ticks? And just over 30%, almost 40%, have had a definite tick bite. They've identified the tick and removed it from their body. Another third are not quite sure, but they think they've been bitten by something, and a third don't report any tick bite. Virtually all our cases are locally acquired. Some reports say up to 20% are acquired abroad, but in our series, only 5% were acquired abroad. And the rash can be very variable. I mean, you see classical descriptions of erythema chronicum, this spreading bullseye rash, sometimes pale at the centre, sometimes more inflamed. But in my experience, having seen a lot of these rashes in Hampshire, they can be very florid, they can be very faint, they can sometimes look very inflammatory, and sometimes they're hardly visible at all. And so I'm just showing you a few here. This is one that appears to be fading, but you can see a red centre and a very faint expanding circular ring on the side of a trunk, somebody's trunk there. A child with nothing in the centre at all, but this very faint, again, ring, expanding ring on the side of the hip. A conservation worker, so you can be bitten anywhere, of course. He spent his time wading in reeds on the banks of the Itchen and the Test, and a tick has bitten him on the lower abdomen. And again, a variety of rashes on arms and legs that were associated with positive Borrelia serology. Age, most series seem to report a sort of a biphasic age distribution, and perhaps that's just associated with those age groups that spend most time in the countryside. But we've seen most, as you can see here, in young children, and then middle-aged folk in their 40s, 50s and 60s. Where we've got a history of tick bite, not surprisingly, the bite usually occurs in the summer months, May, June and July, with the first symptoms, whatever they may be, following some weeks later, and a diagnosis often a bit after that. So there's a bit of a lag phase in terms of symptoms and then diagnosis. And these are the presenting symptoms of our 508 patients. 70% presented with a rash as their primary symptom, and that fits again with most series. Most series seem to report 70 to 75% first symptom being rash. Some with arthralgia or flu-like symptoms, or pyrexia and flu-like symptoms here. We've had a couple of possible cardiac cases, but it's often a little bit difficult to be absolutely sure that the cardiac problems are associated with Borrelia infection. And quite a reasonably high first presentation of neuroborreliosis. And of the neurological presentations, the majority of those are single cranial nerve palsy, seventh nerve palsy. So I really think with any seventh nerve palsy, it's worth doing Lyme serology, even though, of course, there are multiple causes for seventh nerve for Bell's palsy. Multiple cranial nerve palsies, less common. Radiculopathies, about a quarter of them presenting with neuroborreliosis, present with severe pain in a dermatome distribution. That is often quite striking. Meningoencephalitis relatively rare, and myelitis also relatively unusual. And here's some of the seventh nerve palsies resolving in various patients. Often the children with seventh nerve palsies have been bitten somewhere on the head, in the scalp. So if they've had a rash, the parents haven't, neither the child nor the parents have noticed it, and they then develop a seventh nerve palsy. It can happen at any age, as you see there. And this was a remarkable patient who presented with some bizarre neurological symptoms, and it's reminded me that really with any bizarre but definite neurological symptoms, it's worth screening for Lyme, because this chap noticed some fine motor changes that were objective and demonstrable in both hands, and he was thought to have a cervical disc problem, so referred to the orthopaedic surgeons, who scanned him and found this lesion in his cervical spine. And this is some years ago now, and I'm not sure, radiologically at the time, that was reported as a possible neurological malignancy. So he was referred to the neurosurgeons, who said, well, it's not really operable there. Why don't we send you to the infection doctors to rule out any myelitis inflammatory causes? And he had a battery of serological tests, of which the only one that was positive was a rip-roaringly positive Lyme ELISA. And so he came into hospital. He'd actually, by this stage, having been told it might be a tumour, had started planning his funeral. And he was a young chap in his late 30s with young children. But he came into hospital, had a few days, not months or years, a few days of IV ceftriaxone, and after about day 3 of IV ceftriaxone, he said, I just feel so much better. Not only are my neurological symptoms starting to resolve, but I feel better in myself. I'm no longer depressed and miserable and having sleeping problems. I'm sleeping better. And he then went on to oral doxycycline on about day 5. We gave him quite a prolonged course because this was such a striking lesion, and a few months later, as you can see, the lesion has resolved entirely, and he's remained well ever since, without any long-term symptoms. So we have now, we've set up a formal Lyme clinic in Winchester, and are encouraging referrals really from all over the region, if not the country. But what we're keen to do in the clinic is see real Lyme, true Lyme, early on. So we're encouraging our local GPs to refer early Lyme, because I think it's going to be very interesting to monitor the evolution of serology in these patients, which hasn't really been done properly. And so if we can pick them up early on in the disease and persuade them to come back for regular serological testing, we can see how those immunoblock bands evolve over time. Also, if we pick them up right at the early stage with primary Lyme and they've got a skin lesion, we're planning to biopsy the lesions, which I want to culture. I know Tim Brooks is not terribly keen on culture because he prefers molecular things, but I think it would be very helpful to try and culture the organisms to be able to develop a better understanding of the protein structure of our local strains. And of course, we can PCR it, and we can monitor the clinical progress as well as the serology on treatment. We're also getting referred a lot of chronic Lyme disease, which, in my view, often is not Lyme disease, which is why I'm trying to develop this new disease. Because Lyme disease, as we've discussed, patients often have a history of having been bitten by a tick. They have positive serology by ELISA and immunoblot. They tend to have normal hematology and biochemistry investigations. Sometimes the CRP can be marginally raised. They present with objective symptoms, with a rash, and sometimes non-specifically unwell alongside that. And if they present later, they present with objective neurological findings, also with non-specific symptoms of fatigue and sleep disturbance and depression and so on. But you can usually elicit these objective findings on clinical examination, and when you treat them, they almost, of those 508 patients, they've all responded to treatment quickly in short-course antibiotics. A few of them have had persisting symptoms, which I think is related to inflammation, but none of them have needed to come back for regular consultations as a result, and they've all got better. Whereas chronic or seronegative Lyme disease, which I want to now call chronic arthropod-borne neuropathy, I think is a mixed bag of diagnoses. I mean, the etiology is not known. Some of these may be genuine infections of unknown organisms. Some of them may be psychiatric illnesses, but they are a mixed bag it's very hard to pinpoint what is going on, and indeed very hard to manage these patients, because they also say they've been bitten by a tick, but you never quite know whether that's sort of retrospective, and some of them say, well, I've been bitten by a mosquito, it's been transmitted by a mosquito or a flea or something else. Their serology is largely negative or confusing. They may have a cross-reacting band on the immunoblot, which is one of the dangers of doing these complex serological testings. They also have normal blood tests. They don't present early. They often present saying, I've been ill for 20 years. They present with non-specific symptoms: fatigue, myalgia, cognitive impairment, arthralgia, general paresthesia, non-specific neurology. And if you examine them, there is nothing to find. They don't get better with anything. You can try treating them with antibiotics, short course. They often say they get better with a short course of antibiotics, but then their condition relapses when you stop. So relapsing illness is not uncommon. What might cause persisting symptoms, which I don't really see in true Lyme, but you certainly see in these chronic patients? Well, it could be some degree of tissue damage. It could be an ongoing immune reaction against self-antigens. It could be untreated disease. It could be reinfection. It could be another illness. And I think a lot of research is needed to define each of these, and we may never get to the bottom of it. Chronic Lyme, or CAN, as I now want to call it, is a very, very challenging condition, as I'm sure many of you appreciate. So I would recommend again that if you have patients with so-called CAN, you direct them to Lyme disease action first. Some groups of chronic Lyme sufferers believe it's a massive government conspiracy, and we're all hiding something. We point out that we're there as doctors to try and help patients and to relieve suffering and make people better. And the fact that we can't do it is just a reflection of our poor understanding of their illness, not that there's some awful conspiracy going on. Their symptoms in CAN, of course, resemble many other conditions. And, of course, many of them do have these other conditions: chronic fatigue, fibromyalgia, mental illness, depression, and chronic neurological problems as well. Those with chronic neurological conditions like MS or ALS are often desperate to have a treatable diagnosis, and so turn to this issue of Lyme disease. People who treat chronic Lyme disease often advocate months and years of antibiotics, and unfortunately the whole situation is again complicated by laboratories abroad which do tests which are not scientifically validated. Many of these patients, in their desperation because they've not got better, will go to alternative practitioners. The Breakspear Hospital in Hemel Hempstead is one, who will not send tests to UK laboratories. They send tests to a German laboratory in Ausbach or Igenex in Alo Palto in California. And guess what? They get a positive result back. Not only do they get a positive result back for Borrelia burgdorferi, but they get a positive result back for Anaplasma, Ehrlichia, Babesia, and a multitude of other co-infections, which, of course, reinforces the beliefs of these patients that they have a treatable infectious disease. So it's a really complex issue, and although these patients have chronic fatigue and lack of energy, they seem to have a massive amount of energy to campaign for their illness. And they spend an inordinate amount of time writing to their MPs or to the Department of Health, or slagging off doctors who are trying to do the best for them, because they believe that there's some massive conspiracy going on. Now, I'm presenting the extreme here because there are plenty of people who really do believe that they were well one moment, bitten by a tick, and then have been unwell since. So I want to stress there is, I think, a spectrum of illness here, of which these conspiracy theorists are the sort of worst end of the spectrum. And here's a chap, I just got this picture off the internet, but he's from the United States, and here he is displaying, describing his illness and the amount of medication he's needed to take over the past 2 years. And this is only just a photo of some of his meds, injections, and a small portion of his IV treatment. So he is suffering from chronic Lyme. Now, we're all, as infection doctors, aware of many persisting and chronic infections, of microbes that persist in our body. And I've just put up a few examples here. You know, there's lots of viral ones, there's the bacterial ones, fungal ones, protozoal ones. Many of these organisms can exist in our body without causing any active disease. But all of these leave some sort of pathological signal, which is why it is so bizarre, really, if these people really do have chronic Borrelia, that we can find no pathological signal at all. And evidence against many of these chronic Lyme being an infectious disease are listed here. If we did a straw poll in this room and asked, have any of you in the past week, have any one of these 14 symptoms, and apparently 74% of us would say yes. So have any of us had fatigue, arthralgia, headache, myalgias, tingling, dizzy, memory, concentration loss? Many of us would answer positively to those questions in the last week. Chronic Lyme disease patients have been tested with a range of microbiological and scientific tests. They've had LPs done, and in 128 patients, none of them have had positive CSF culture for anything, let alone Borrelia, negative PCR, negative blood PCR, and negative blood PCR during treatment. Again, reinforcing what I've already told you, but objective findings in chronic Lyme are absent and don't seem to develop over time. They seem to be independent of seropositivity if that is present. There's no known antibiotic resistance in Borrelia burgdorferi, so antibiotics ought to work if there's an active infection there. There's an absence of recognised risks often for treatment failure, and there's no precedent really in any other disease for this sort of chronic type illness. So in our clinic, which has just started, our formal clinic, although we've been seeing these patients for 20 years, in September, we saw 32 patients in the clinic, of which 11 had genuine true Lyme, that were either new cases or follow-up patients. 12 of them were this new syndrome that I'm trying to coin called CAN. Other ones that have been sent up either as Lyme or some other condition had another diagnosis. So 2 were bacterial infection, 1 had a dermatophyte infection, 1 actually was typhoid, believe it or not. Tick typhus, another one, Q fever, sarcocystis from a patient who'd been in Malaysia, and cutaneous larva migrans. So an interesting group of patients in the clinic. And so I've gone over time a bit, but I think we've got plenty of time, Nick. So I've almost finished. But just to illustrate 2 of these patients who were sent up as chronic Lyme. One was a 42-year-old woman bitten by a tick in 2008. She had been travelling in Eastern Europe and Cyprus, but she'd basically been unwell since 2010 with fatigue, lack of concentration, myalgia, post-exertional fatigue, shooting limb pains. All Borrelia tests were entirely negative, and indeed all serology and haematology and biochemistry was negative. She was convinced of a Lyme diagnosis by what she'd read on the internet, and she had a battery of serology done. The only thing that was positive, and it's difficult to know how significant that was a positive IgG for West Nile virus. Now, I'm sure there's some cross-reaction, but I think it's conceivable in her case she might have had a low-grade encephalitis from her travels in Eastern Europe and the southern Mediterranean sometime a few years ago, which might be responsible for her chronic fatigue. Who knows? But it didn't seem to be Lyme disease. A 15-year-old boy, febrile illness with lymphadenopathy in 2012, complete energy loss, lack of concentration, unable to return to school, no specific neurology, diagnosed as Lyme disease at the Breakspear, based on non-validated blood tests, which weren't serology. They were lymphocyte transformation tests. That's another thing to be aware of, that some of these alternative labs use alternative technology which are not specific for Borrelia. He had extensive antibiotics, IV antibiotics and alternative treatments, vitamins and minerals and various other things. But he did have a positive persistent OPC IgM band on the Borrelia with conventional testing. But this often does react with Epstein-Barr virus, and I think all his illness, and he's still EBV positive. Nobody actually tested that before. So he's EBV PCR positive, and I think this illness back in 2011 was glandular fever. And that's the cause of his slightly persisting symptoms, although he is recovering. So in the clinic, I'm hoping to offer a panel of tests, largely because the patients demand it. And I think if we've done a wide range of infection tests, then at least we can reassure the patients that they have or have not got those infections. And so I've got over my time a bit, but I think we're good for time. So I'm going to stop there. I'm very happy to try and answer any questions if there are any. 1 or 2 quick questions, and then we'll move over to the next session. Thank you very much.